Hello, my name is Alex Wheatley. I'm a graduate fellow at the Woodrow Wilson School of Public and International Affairs at Princeton University. I'm based here in DC at HHS's Office of Global Affairs, and this video summarizes my recent report on health system strengthening in the Federated States of Micronesia and the Marshall Islands, as prompted by the potential 2023 transition in health financing. The project began in February 2018 with the question, what type of engagement strategy between the Federated States of Micronesia, FSM, the Republic of the Marshall Islands, RMI, and the Department of Health and Human Services, HHS, would facilitate the most productive relationship, support sustainable health services, and contribute to improved healthcare outcomes? You can think of the research as having two parts. First, to understand how these nations are currently engaged around health, and second, to take best practices from this engagement and from alternative health system support models. The final product of this research was a policy analysis report completed and circulated in December 2018. This report is available on the Pacific Island Health Officers Association's website. To complete this project, I drew on government documents, academic literature, news reports, articles, and books. I also interviewed individuals from the Pacific and from the US government, as well as from the nonprofit world and private sector. Interviews were semi-structured, so when trying to understand the current health landscape in FSM and RMI, I sought many perspectives on a wide variety of topics. When I was trying to understand alternative health system support models, I spoke to fewer people, but I really dove into the details of those models. Alright, this is my one fun animation. I use it here to emphasize the complexity of HHS, FSM, and RMI engagement around health. The questions I laid out in the last slide are tough questions, and I found that there are no easy answers. A lot of people I spoke with for this research told me that they were excited to see the results of this project and they thought it'd be really helpful. I sincerely hope it is helpful, but I also want to state up front what the goal of this project was. The goal of this research was to be a resource for policymakers in the lead up to 2023. My report doesn't provide very many answers, but I hope it does provide the necessary scaffolding for the discussions that will happen prior to 2023. I'll also use this moment to state that this presentation and report represent my views and not those of any group I'm associated with. Okay. In a good presentation, you're supposed to tell people what you'll say it, and then tell them what you said. So here's what I'll spend the next 30 minutes talking about. I'll first review the health landscape in FSM and RMI. I'll then compare current engagement with three alternative U.S. government health system support models, that of the United States Agency for International Development, or USAID, the model of the President's Emergency Plan for AIDS Relief, or PEPFAR, and U.S. government support for American Indian and Alaska Native communities through IHS, or Indian Health Service. From these reviews, I conclude that by including FSM and RMI in HHS's domestic authorization and appropriation structures, thereby making these sovereign nations eligible grant recipients in the same way that states are eligible grant recipients, current HHS engagement implies an expectation that these sovereign nations can implement health programs as states can. In some ways, this is a valid assumption. They have US-based health systems, and these nations have seen some growth over the period of the compact. But in other ways, the assumption is not valid. The nations have limited health capacities, significant workforce challenges, developing world disease profiles, isolated populations, and of course, they're sovereign nations. I conclude with a number of policy considerations for HHS, FSM, and RMI. Now we'll move back to the beginning and start at part 1, reviewing the engagement context. There are 6 U.S.-affiliated Pacific Islands. 3 are territories, and 3 are freely associated states, or FAS. The territories are Guam, the Commonwealth of the Northern Mariana Islands, or CNMI, and American Samoa. The FAS are Palau, FSM, and RMI. U.S. ties to these islands date back to World War II. Before World War II, these islands were Japanese colonies. During World War II, they saw significant U.S. activity, including when the Enola Gay, which carried the atomic bomb bound for Hiroshima, took off from Tinian Island in what is now CNMI. Post-World War II, these islands were grouped into the Trust Territory of the Pacific Islands, under trusteeship of the United States. In my report, I focus on 2 of the FAS, FSM and RMI. These jurisdictions became independent in the 1980s. In 1986, they entered into a compact of free association with the US. I'll come back to that on the next slide. For listeners who may be less familiar with FSM and RMI, this slide covers what you have to know about these nations in order to understand this project. First, these are really small nations with really dispersed populations. You can see the numbers and the map on the slide, but for context, FSM and RMI's populations and geography is equivalent to roughly 1% of Texas's population, spread out over 5 Texases worth of Pacific Ocean. Another important takeaway, these are considered middle-income countries. Their health systems operate in a developing world context, and while their GDPs are growing, mostly thanks to tuna revenues, economic opportunities are relatively slim, and there is significant outmigration to neighboring countries. A few other facts at the bottom of the slide. On the left, note that FSM's 4 states, Yap, Chuuk, Pohnpei, and Kosrae, have significantly more autonomy in FSM's government structure than do US states. And on the right, note a particularly important U.S. interest in RMI. Kwajalein is an Army base and hosts the Ronald Reagan Ballistic Missile Defense Test Site. It's relevant to note here the U.S.'s nuclear legacy in RMI. The U.S. conducted nuclear testing in RMI between 1946 and 1958. This significantly negatively impacted segments of the Marshallese population. Getting back now to that Compact of Free Association I mentioned earlier. The Compact, also called COFA, was a way for FSM and RMI to maintain a special and close relationship with the U.S. government. Through the Compact, FSM and RMI receive significant economic assistance to the tune of roughly $60 and $90 million each year, much of which goes to health and education. So they receive economic assistance, protection from the U.S. government, or from the U.S. military should they ever need it, and unrestricted work and travel in the U.S. without a visa. In return, the U.S. reserves the exclusive use of FSM and RMI's lands and waterways for strategic purposes. All aspects of the Compact extend in perpetuity except for the economic assistance. The majority of economic assistance is slated to end in 2023. The goal of that economic assistance is to promote economic self-sufficiency and budgetary self-reliance. Those are terms you'll see in a lot of discussions about the Compact. In 2003, the Compacts were amended to establish trust funds to help with that 2023 transition. I won't go into detail here, but the key takeaways are that there's some uncertainty about what will happen in 2023. People aren't sure exactly how the transition will go from direct assistance, which is administered by DOI, to payouts from the trust funds. There are concerns about how the money will be distributed and concerns that the money won't last. And there are also some U.S. agencies who have been engaged in FSM and RMI that will pull out of the region in 2023. Related to the Compact and its unrestricted travel for individuals from FSM and RMI, this slide illustrates where FSM and RMI migrants have settled in the U.S. The figure is from an old GAO report, but I've added in yellow more recent data that illustrates where the roughly 60,000 Micronesians in the U.S. currently live. As you can see, there are big populations in Guam and Hawaii, as well as significant populations in Washington, Oregon, Arkansas, and Texas. These migrants are associated with significant education, health, public safety, and social service costs. The COFA has baked in assistance for the 3 nearest territories and states to help cover some of this cost. It's called Compact Impact. It included nearly $314 million for healthcare between 2004 and 2010. The contiguous U.S. does not receive Compact Impact assistance. This migration is relevant for economic and global health security concerns. I'll focus now on the economic assistance portion of the compacts by looking at government expenditures in FSM and RMI. The figures here illustrate FSM and RMI government expenditures in 2016. Compact financing is shown in white, light blue is additional U.S. government support from non-compact sources, and dark blue is domestic or non-U.S. government support. You can see that more than half of government expenditures were financed by local sources or non-U.S. government sources, while 1/4 to 1/3 of government expenditures were financed by the Compact, and an additional 10 to 15% by other federal grants. The big takeaway here is that the U.S. government is significantly invested in these nations, and the spread of financing is roughly 50-50 local U.S. government. When we narrow in on financing for health, however, financing is skewed more toward US dollars. The figure on the left shows that local revenues are expected to support just 5% of FSM's health budget in 2019. 95% of health financing will come from US government sources. The middle figure shows RMI's expected budget for 2019, where local revenues are expected to finance 41% of health expenditures. This is a pretty big jump for RMI, as local revenues financed just 15% of health expenditures in 2018. The takeaway here is that these nations are heavily dependent on US government financing for health. Of that US government financing, HHS finances just over a quarter of both nations' health systems. On the right, you can compare this with an average state's health financing. Local revenues make up 42% of financing. A comparable array of HHS grants provide another 16%. Other federal grants make up another 32%. These include things like Medicaid, for which FSM and RMI are not eligible. And then other sources, including private and nonprofit partners, provide that last 10% in yellow. In all, FSM and RMI are more dependent on US government financing in the health sector than in other sectors, and FSM and RMI are more dependent on HHS financing than our states. Okay, so zooming out a bit here, I've now established that there are these two streams of US government financing for health in FSM and RMI, compact funding in blue and HHS funding in orange. Both streams' futures are a little bit uncertain. This is simplifying things a bit, but in 2023, blue financing will end to be replaced by revenues from the trust funds. Barring a change in legislation, it's assumed that RMI and FSM will remain eligible for HHS grants past 2023, but no one really knows what will happen. This is why people are concerned. I do want to point out that these two streams of financing are actually pretty different. Compact funds are catered to FSM and RMI, while HHS funds are generally designed to supplement mature state health systems. Compact financing derives its authorities from GEMCO-GEMFAC processes, which include FSM and RMI leadership. HHS financing derives its authorities from Congress, in which FSM and RMI leadership are not represented. Compact financial assistance through DOI allows for advance funding. HHS grants are awarded under a reimbursement model. And the goal of compact financing is to promote self-sufficiency. Health is part of that, and the authorizing language for the compact's health financing is very general. The goal of HHS grants awarded to FSM and RMI are more narrowly focused on public health, primary care, and preparedness, and the authorizing language is generally much more specific. And then, of course, they have the different concerns around the 2023 timeline. All this to say, 2023 presents a crossroads. The combination of low levels of local financing, limited health system development, and uncertainty around the financial transitions in 2023 raises questions for HHS, FSM, and RMI moving forward. You can pause the video if you'd like to read all of them, but here I highlight some of the questions HHS must think through. And here are some of the questions FSM and RMI must think through. 2023 presents an opportunity for FSM, RMI, HHS, DOI, the broader US government, and partners to discuss questions like these. Okay, so at this point, I've established that there are these two streams of financing to FSM and RMI from the US government. My project specifically focuses on HHS. HHS supports states and seeks functional local healthcare systems in general. FSM and RMI are not states. So the question is, how different are they from states? This question aligns with my broader research question, which I've written in italics there at the bottom, just as a reminder. How different are they? Well, I looked at data. Relative to the US, FSM and RMI have younger populations, shorter life expectancies, higher infant mortality, exceptionally high rates of tuberculosis, low immunization rates, higher rates of obesity and diabetes, and fewer available caretakers. You can pause now to review the table in detail if you'd like, but I want to highlight the tribal comparison before moving on. FSM and RMI health indicators are more similar to American Indian and Alaska Native health indicators in the US than they are to the broader US population. It's not a perfect comparison. I mean, there are 573 tribes and 2.3 million American Indian and Alaska Native people in the US, relative to just 200,000 total in FSM and RMI. but it is an example of another sovereign entity within the U.S. domestic system. How different are they? I also looked at structures. I compared the structure of FSM-RMI's Division and Ministry of Health with that of a territory, CNMI, and of the Pacific Island state of Hawaii. FSM's Division of Health is arranged around state departments of health, while the others, ministries of health, are arranged around topic areas. This decentralization is to be expected, given the relative autonomy of FSM states. How different are they? I also looked at priorities and goals, as stated in guiding health documents. I know there's a lot going on this slide, just look at the colors. All jurisdictions had some priorities related to quality and access, highlighted in red, disease burden, blue, administrative challenges, green, technology and data, yellow, and social determinants of health and environment, in purple. What varied between each of these four was the relative balance of these priorities and the language used to describe them. Again, how different are they? I looked at operations and financing. To highlight just a few of the things on this slide, budgets and per capita expenditures varied significantly. Staffing ratios were similar among FSM, CNMI, and Hawaii, not RMI, and all offered some of the same services, including immunizations, vector control, and food safety. CNMI offered more services than either FSM and RMI, although I wasn't able to compare those three with Hawaii. Lastly, and most importantly, to understand how different FSM and RMI are from states, I talked to people. I gathered more than 84 unique perspectives and conducted more than 40 hours of interviews. I asked individuals from FSM, RMI, the U.S. government, and partners about challenges facing mutual health engagement. I've summarized their responses into the 5 buckets you see here: leadership and governance, financing, workforce retention, communication and technology, and advocacy. A few of the most commonly cited challenges were insufficient financing, challenging funding flows through the government, a lack of data, staff turnover on both sides, and workforce development issues. I want to highlight one advocacy point that surprised me. Outside of the U.S. government, most individuals seem to underappreciate the role that the U.S. Congress, not HHS nor the operating and staff divisions within it, plays in determining much of the availability and flexibility of the financing that reaches FSM and RMI. The way to shift financing amounts and structures is really through Congress, not a department like HHS. It'll require legislative advocacy, and that will require better data around which advocates can craft a narrative and justify calls for change. Conversations like this helped bring all these ideas together and gave me a better sense for the overall health landscape in FSM and RMI. So in all, how different are FSM and RMI from states? Pretty different. My next question was, if they're so different, are they perhaps more similar to other populations for which the U.S. government provides health support? And if so, are there any best practices that could inform U.S. government support in the Pacific? I analyzed 3 alternative models, as shown here: the Indian Health Service, USAID, and PEPFAR. They were chosen because they illustrate U.S. government support for health delivery and services in sovereign contexts. IHS targets tribal units within the U.S., which are sovereign political entities. USAID is the traditional lead for international health and development assistance, and PEPFAR leads the U.S. government response to HIV and AIDS around the world. I'll briefly review aspects of these models that could inform HHS, FSM, and RMI engagement, but for more detail on each, feel free to check out the report on PHOA's website. First, IHS. The figure above gives a general overview of IHS's activities to fulfill the government's moral trust responsibility for the health and well-being of American Indian and Alaska Native populations. As the central box shows, IHS activities include everything from construction and maintenance of facilities to direct clinical services. I've highlighted in green the aspects of the IHS model I found most interesting for FSM and RMI: contracting and compacting mechanisms. Through contracting, to explain it pretty simply, a tribe can basically tell IHS, hey, you know that $50,000 you were going to use for a tobacco cessation program? Give it to us, we can do it better. With 3 years of clean audits, a tribe can also compact, which is to say, tell IHS, hey, you know that $1 million you are going to use to care for our entire community? Give it to us, we can do it better. This model is attractive for FSM and RMI because it gives tribes additional flexibility to adapt programs to their needs, and it gives them access to a larger pool of potential government funding, as tribes can apply for grants from other HHS agencies like HRSA or CDC. The downside here is that compacting and contracting mechanisms probably won't function in isolation from the broader IHS model. For example, they rely on Medicaid and Medicare eligibility and co-located non-IHS resources. However, one component from the story of U.S. government support for American Indian and Alaska Native populations that does translate to FSM and RMI is the need for strong advocacy and high-level legal action. The trust responsibility of the government was established through court cases, and strong voices in Washington, including groups like the National Indian Health Board, continue to aggressively protect and pursue the best interests of American Indian and Alaska Native populations. FSM and RMI have not benefited from comparable legislative advocacy. These are my big takeaways from IHS support and U.S. government support for AI-AN populations. Moving now to the PEPFAR model. PEPFAR is built around HIV and AIDS programming. HIV and AIDS are less of an issue in FSM and RMI, so PEPFAR is not directly relevant. However, many aspects of PEPFAR's approach could inform FSM, RMI, HHS engagement. I highlight three here: the focus on sustainability, the emphasis on data, and again, the value of high-level advocacy and congressional support. The theme of data, collecting it, reporting it, and advocating with it, is shown in green. To work backward along that green line, country operational plans and sustainability index dashboards are two PEPFAR processes that engage all parts of a community to plan out progress toward HIV control. In doing so, the creation of these documents promotes local ownership for HIV programming, and the data collected in support of these goals is both used to keep stakeholders accountable and to justify continued support from Congress. In this way, PEPFAR illustrates the value of a data culture. Quality data helps leaders to isolate and address problems, as well as enables advocates to justify the need for ongoing support. FSM and RMI's health system development efforts may benefit from targeted efforts to improve data capacity. Some of these efforts are already underway, but those are my big takeaways from the PEPFAR model. The last model I consider is USAID. USAID is the traditional U.S. government lead for international health system development. In fact, there's a USAID office in the Pacific, but it doesn't operate health programs in FSM or RMI. HHS, rather than USAID, is the lead for health system development in the sovereign countries of FSM and RMI because health assistance to these nations began while they were territories, and it came out of the domestic budget. Compact assistance and grants from federal agencies continue to come out of the domestic budget. The most important takeaway from the USAID model is its underlying focus on development. As shown in green among the objectives, health is not the primary focus of USAID's work in a country. Instead, it's a critical component of development alongside other goals like peace, democratic governance, economic growth, and the like. This is different from the HHS model, which focuses on reducing health burdens without direction from development goals and expanding capacity within mature state health systems. You can think of it like this. HHS does not define the health or developmental priorities that would ultimately guide FSM and RMI to apply to a cross-section of grants that might support a holistic health system strengthening approach. Health efforts in FSM and RMI may benefit from a broader developmental schema and broader authorities to implement it. It's relevant to note here that FSM and RMI enjoy comparatively high rates of per capita healthcare financing through HHS support, roughly $200 per capita. Were U.S. government support to be transferred from HHS to USAID, USAID's global responsibilities and multi-sectoral portfolio may undercut its ability to sustain the high levels of health-focused funding these nations currently enjoy. That's my overview and big takeaways from the USAID model. Though I only considered governmental models in the last few slides, it's also important to remember that HHS, FSM, and RMI do not engage in a vacuum. NGOs are resources for advocacy, coordination, technical assistance, and education efforts. Multilateral groups are resources for things like networks and financing. Public-private partnerships have facilitated innovation and technology transfer. And of course, the broader Pacific region hosts other governmental influences. China's presence in the region has grown. Australia has traditionally been more prominent in the South Pacific, but is investing in health and health security throughout the Pacific today. And the health of territories is more closely tied to FSM and RMI. I haven't used territories in Palau in this research because territories are governed by different rules and regulations, and Palau is a high-income country with a smaller, differently structured population. But both territories and Palau, could contribute to and perhaps learn from some of the concepts discussed in this research. All this to say, there are a lot of players orbiting around FSM and RMI health system development. Okay, I've now reviewed the context and compared alternative support models. In this last section, I'll review policy implications. I raise many in my report, but in this presentation I'll highlight just 3. I'll compare HHS and USAID, I'll consider FSM and RMI sustainable financing, and I'll discuss HHS departmental coordination and strategies. This slide presents some of the policy questions and suggestions I discuss in my report. You're welcome to read the report for further detail. I show this slide just to illustrate that the report is meant as a resource for 2023 planning, and these suggestions are raised with a goal of more productive health system strengthening efforts now and after 2023. Note that in the report I also look to long-term issues, including the potential repercussions of outmigration as a result of climate change or, significant health issues. Okay, now to that first policy question. Why HHS? FSM and RMI are foreign countries. International health system development is typically USAID's territory. Why is HHS the US government health support lead in FSM and RMI? And should it be? In researching this dynamic, I found good reasons why HHS leads US government health support for FSM and RMI. HHS has health-centric expertise, established relationships, and FSM and RMI do present and share some domestic health concerns. FSM and RMI also benefit from perhaps more and more secure financing through HHS rather than USAID. Given all this, I think HHS is a good fit for FSM and RMI. However, more effective engagement is possible insofar as HHS can embrace a more holistic developmental perspective. FSM and RMI are not mature state health systems. They will need more and different types of support to sustain progress. In this regard, USAID likely has the programmatic expertise and capacity to complement HHS efforts. They have that multi-sectoral, development-focused portfolio. Though logistically unlikely, a joint HHS-USAID approach could bring the best of both worlds to FSM and RMI health system development. This next question is something I struggled with throughout this research. The goal of development-oriented financing is always local ownership and sustainability. But how do countries own financing that ultimately requires accountability to a different country's standards and plans? How can FSM and RMI locally own external financing? What I found is they can't. Ultimately, to own their financing, FSM and RMI must provide it. Sustainable financing relies on local revenues. That said, there are a few shifts in processes and perspectives that may help to foster a sense of ownership as FSM and RMI seek ways to increase local revenues for health. Consider PEPFAR's country operational plan processes. PEPFAR engages a community early, which then hammers out a costed strategic action plan and uses that document to coordinate among funders. The process is very much driven by local forces, though accountability and data and advocacy go all the way up back to DC. State budget processes have a similar approach, as you can see on the right. Priorities are set first, and then leaders go shopping for financing. Both of these are seemingly flipped from what happens in FSM and RMI. The sense I got was that first, available financing is established, and then priorities are set to match and maximize that potential financing. It leads to a sense of navigating among grant opportunities rather than leading health system financing. This was a concern often shared in interviews. I'm not sure the details of how to move from navigating to leading, but I think a costed strategic action plan may help. Again, this is all with an eye to sustainable financing through and past 2023. I'll move now to the last policy consideration, departmental coordination. As we look to 2023, I think it's in all partners' best interest to maintain FSM and RMI's eligibility for HHS support. Assuming that HHS financing to FSM and RMI continues, two dynamics are worth considering. The first is more coordination within HHS for FSM and RMI. Establishing common metrics or goals, promoting intra-HHS communication, and institutionalizing best practices are things that could contribute to breaking down silos inherent in HHS appropriations and could better enable local ownership within FSM and RMI. More coordination would also make interagency discussions about what to do in 2023 simpler. An FSM-RMI strategy is also valuable to HHS as a potential blueprint for HHS support for low-resource, isolated, or developing world contexts moving forward. The second dynamic is a shift toward development and local ownership. This could be done through partnership with USAID or through efforts within staff and operating divisions. As I stated at the beginning of this presentation, the goal of this project is to be a resource for the discussions that need to happen in advance of 2023. These are discussions within HHS, within FSM and RMI, and between these partners. There are a lot of moving parts here and a lot of questions that need to be answered. But 4 years out from 2023, now is just the beginning of this planning process. From this research, I'm optimistic that partners can work together to achieve maximally productive relationships, improved healthcare outcomes, and sustainable health system development in FSM and RMI moving forward. I hope you've enjoyed this presentation. A reminder that the full report is available on the PHOA website. I hope you'll check that out. Thanks for listening, and many thanks to Shibroto, Erica, Amy, Han, OGA, Cincy, and to everyone who shared their perspectives for this project.